Good morning, afternoon, I guess, at this point. How's everybody today? All right. So I did want to start out by saying thank you for welcoming me to the University of Findlay. Again, as Dean Stanislavski said, I'm very proud to be a member of your assistant faculty. And thank you very much for having me. And also to Blanchard Valley Regional Health System and College of Pharmacy for supporting this event. It's really nice to be able to present and discuss and collaborate with you guys in this type of format in a university setting. It's a rarity, so I hope you appreciate the fact that Findlay is offering this with Blanchard. So thank you again for the invitation. So without further ado, if my slide will advance. It's going to be a long 85 slides. Good? Oh, look at that. Are we good? All right. Okay, so your objectives, again, I was asked to talk about MRSA infections, and we could talk about for weeks. So really how to gear a presentation for students, physicians, pharmacists, and really try to keep it down to earth. So what we want to do is really talk about driving appropriate therapy. We have so many options for MRSA infections right now. What do we choose? Do we just choose the cheapest and go with it? Are there differences? How do we as clinicians make the appropriate recommendations, and how do we apply the guidelines, the very new and recent guidelines, which were just recently released in February, to the treatment? Does it really change what we do? So that's kind of what we're looking at. Our objectives are lengthy, and you all have them. One thing I did do is you will see that these slides are a little bit more wordy, and that's because I knew there was a lot of students in the room. So it might be difficult for you all to follow along with some of the things, and I wanted you after the fact to be able to go back and easily kind of figure out what we were saying and where we were going. So we are going to run very rapidly through these slides, and we'll hope to hit on the high points. Okay? If there's any questions, we can talk about it at the end. So case one. This was a patient at our institution. This was an 80-year-old male with diabetes, obesity, stage 4 chronic kidney disease, a pretty bad peripheral vascular disease, and he had coronary artery bypass grafting times 4 vessels about a year and a half prior to this. And he was treated at our wound center chronically. He had 6 or 7 really bad stasis ulcers, which is common. We do see this. And he did have a history of MRSA in the past. What happened was, and what's common is these patients get very poorly vascularized, and they have multiple procedures, and what you typically see is that it's typically the toes and the feet that go first. So he has a lot of ischemia to his feet and toes, and they had to do a bypass grafting of the vasculature, and mainly in the left leg. So we had left lower extremity revascularization. So they went into the right leg, took some pieces, put them in the left leg to basically revascularize and get more blood supply. Okay, that's a common procedure in patients that have these comorbidities. What happened was, afterwards, for those of you who've seen wounds like this, anybody want to tell me what that is? Why we're here today? MRSA. So this was in one of his surgical sites. And you can see it's called dehiscence, where it actually swells up and bursts through the sutures because of the infection. And it's kind of difficult to see with the lighting, but there's a lot of kind of clear to red pinkish fluid draining. That's called serosanguinous fluid. Very typical of what we would see. This is a just classic infected surgical site with MRSA. The second wound on the other, pretty much the same. Okay? So what we did, obviously it's post-operative MRSA at the surgical sites. IV vancomycin was given, just as we normally would. Troughs were maintained. The patient was given a loading dose of vancomycin. Troughs were between 15 and 20, consistent with the guidelines. The MIC of MRSA was not known at the time. So this patient was treated, and what happened was it failed. He had over almost 40 days of vancomycin, in and out of wound care, painful debridements, and ended up having to have bilateral below-the-knee amputations. He was subsequently treated after that surgery with a higher dose Daptomycin, 8 milligrams per kilogram, and actually healed up very nicely and is doing quite well. And it was later found that the MIC for this MRSA isolate was 1.8, which would be, for the pharmacist in the room, susceptible, intermediate, resistant? Susceptible, okay? So case number 2. This is a community-acquired patient that came in, presented to the ED for evaluation of a spider bite, woke up the previous day with a raised red bump on his knee, no recalled injury. He did not see a spider. He had gone to the gym the previous day, exercised vigorously, and then soaked in a hot tub. There was really nothing wrong in the ED other than this. He was afebrile, non-toxic appearing, didn't have any other issues. What they did was, of course, incision and drainage, which is recommended. They drain the mass. And if there's any infectious disease physicians or pharmacists in the room, you'll see that you can see that almost wick-looking material that drained out of the abscess. It's congealed pus from inside an abscess, which I know is excellent to talk about right before lunch, right? Okay, so normally we would do incision and drainage. If the patient was at a higher risk for maybe developing something, we would give you antibiotic therapy at that point. Or if it just really didn't look nice, we would give you antibiotics. So this patient actually did get incision and drainage, and we cultured, of course, and he got clindamycin, 300 milligrams, 3 times a day, and was to take that for 10 days. Okay, pretty straightforward. And of course, we're going to monitor. So about 12 hours later, about 9 hours later, actually, he returned to the ER, hypotensive, feverish, and this thing just exploded. He had fever, chills, and vomiting. So he's going to get, of course, directly admitted, started on vancomycin and Zosyn intravenously. And the ED cultures returned positive for MRSA, and it was preliminary, of course, so we knew that the preliminary cultures were probably going to be MRSA. 2 days later, we knew that it was MRSA. And it was resistant, actually, to erythromycin and clindamycin. So the antibiotic we gave him didn't work. It was resistant, and then we had to choose to switch him to an alternative agent. Of course, at this point, we're not going to use an oral agent, right, because he's septic, he's presumably bacteremic, blood cultures are pending, so hence the vancomycin. Okay, so most clinicians, again, this is appropriate. We did Zosyn and vancomycin. That is an appropriate empiric regimen. So my attempt today will be to prove, or at least get you thinking, is vancomycin always the right choice for your patients, okay? We all know about the D-zone test. For those of you who we've talked about in infectious disease, if you've never seen a picture of it, this is what it is. It's an inducible resistance. It actually occurs at the genetic level, and it can be a transfer from erythromycin to clindamycin. So we do this special test in our lab, and if it's susceptible to erythromycin and susceptible to clindamycin, you're okay to use clindamycin. But if it's resistant to erythromycin, then and still susceptible to clindamycin, you have to do this D-test. And most labs will do this automatically. It's what's called a reflex. And they'll give you this. The problem is it takes 2 to 3 days to come back, so you really don't know. So clindamycin is falling into more latter lines of therapy for community-acquired MRSA due to this fact. Okay? So looking at MRSA epidemiology, I don't want to spend too much time on these slides because we've got a lot to go through. First clinical isolate was 1961. 1980s, it really started to emerge as a significant nosocomial pathogen. Initially, almost exclusively healthcare associated. And now we've got about 60% of our skin infections in the EDs and over 18,000 deaths per year from invasive MRSA infections. And unlike hospital-acquired MRSA, we know community isolates are susceptible to many non-beta-lactam antibiotics, which is great. So a lot of people think that we don't want to give it as much severity as a hospital-acquired MRSA isolate would be, and that's in fact not the case. It's good that you can treat this as an outpatient with oral antibiotics, but there are also, it's genetically different from hospital-acquired MRSA, and that you have subtypes, and some strains of community-acquired MRSA can actually be much more toxic and lethal than some hospital-acquired strains. So there's genetic differences, and some of those can work to the advantage and to the disadvantage of that treating clinician. This again, going through the types, I don't want to spend too much time on these. I'll just let you read through. And our current treatment options for community-acquired MRSA, we have Bactrim, the tetracyclines, mainly doxycycline and minocycline. Doxycycline seems to be the one that's used most often. Clindamycin, rifampin and macrobid, and linezolid, which is Zyvox. And our treatment options for hospital-acquired MRSA have now just recently gotten bigger with the addition of cephalosporin, which covers MRSA, which we'll talk about in a little bit. So Vancomycin's history. Again, I want to spend a little bit of time on vancomycin because I want us to understand, where we're coming from, and that'll better allow us to understand where we're going. Vancomycin was isolated in 52 from a jungle in Borneo from a soil sample. The microbe produced a fermentative byproduct that they found to be susceptible or to be able to kill staph isolates. It was found to have in vitro activity against Staph aureus, including penicillin-resistant strains, which was a growing issue at the time. And when they tried to see if resistance would develop to vancomycin on serial passage, it didn't. So this generated quite a bit of interest. Now remember the times back in the 50s. The initial clinical experience was positive. So there was an extensive emergency use program. It was automatically approved, sort of grandfathered in by what was then the FDA now. And they basically said, well, go ahead and use the drug. We're going to approve it. And just collect patient case reports and let us know how it goes. And we'll go from there. So would any drug get approved right now with that type of method in our country? So absolutely not. And so basically it was very, very much open label data in the 50s. And it was named from vancomycin. This is a question I asked some of my students is, do you know what the word means, where it came from? And it came from the word vanquish. Okay? So we'll talk about that later. Early 60s, we know methicillin resistance was documented and growing. Vanco was found to be effective against these strains. It started getting more widespread use. This is where the term Mississippi mud came from, and it was actually from the appearance. So when vancomycin first came out, it had that brown, muddy, nasty, dirty-looking color, and this is actually where most of the toxicities they thought came from, was just due to all the impurities inside vancomycin. It's much greater, much more improved, much more purified now, and those toxicities aren't even close to what we saw when vancomycin first came out. But in 62, it's important to note that the Kefauver-Harris amendments, which don't mean a whole lot to all of us, but what I want you to understand is that this was that whole European thalidomide crisis, and this is when the FDA said, you know, we probably should require some more efficacy and safety data and some more rigorous testing and study before we approve drugs, but let's start from here and go forward. So vancomycin and a lot of other drugs were kind of grandfathered into this process. And in the 1970s, we know this is where MRSA really started to be rampant. Rekindled interest in vancomycin. It wasn't until that time in the 70s that the actual pharmacokinetics of vancomycin were even determined. And then in the 80s, we know that it accelerated rapidly. And in the mid-1980s, there was a big wake-up call. And even into the early to mid-90s, 90, 94, where VRE was really starting to come out. And it really was a wake-up call to a lot of clinicians saying, you know, we're using this like water. Should we really evaluate its use in therapy? Okay, so that happened again in the 70s. And the high levels of resistance were documented in 2002. And those are the ones that you may have heard about in the news. The Pennsylvania, Michigan, New York, I think there were 6 strains total, and that was vancomycin intermediate or vancomycin resistant Staph aureus, which thankfully we've only had 6 strains of that we've seen. So the CLSI, which is kind of the Laboratory Standards Institute, they set all of our standards for what our targets are, what we shoot for, what we measure in the lab. They changed the breakpoints for vancomycin, and they said, you know, we're really not seeing that great of success. We're seeing rising failure rates. Maybe we really need to look at this, and we'll talk more about this later in more detail. But the breakpoint used to be 4. And you guys all know what breakpoints are. And for the students who had me in ID, and I'm sure you've talked about that in ID, what breakpoints are. So less than 4 susceptible, greater than 4 resistant. You know, right at 4, it's kind of a mixed bag. So they changed it from 4 to 2. Okay? So thinking that let's do that, and then let's also target higher troughs. Let's be a little bit more aggressive. Again, we'll talk about this a little bit more later. Visa and Versa are rare. Something called H-Visa, which we'll talk about in a little bit, was a rising concern. So they really started to question, is it the drug, is it vancomycin, or is it really the bug? Really, is one MRSA the exact same as another MRSA? Okay? So my question is, patients usually receive adequate dose and duration of Vanco. I mean, we're pretty good at getting people to the troughs that they need for the right duration of therapy, loading them up. So why are we seeing more relapses? Because it's happening a lot. And even when I first started practicing, I'm seeing it more now than I did then. And that's only, you know, a 7 or 8 year difference. So we're seeing it a lot more. So what could potentially explain this? And that's really the heart, I think, of the issue of driving appropriate therapy for MRSA, is knowing what we're dealing with, both in antibiotics and in the microbial world. So let's examine this a little bit. It's difficult to go into MRSA without first looking at how vancomycin does against MSSA. Let's just look at simple methicillin-susceptible Staph aureus. This was a study and done a little while ago in 2003, but they looked at persistent bacteremia, relapses, and overt bacteriologic failures. And you can see that in the vancomycin-treated patients, they did worse than just in plain nafcillin-treated patients. My big criticism of this trial has always been the fact that there were 70 patients in the vancomycin arm, yet there were only 18 in the nafcillin arm. So again, the trends are good, but it doesn't mean a whole lot unless we can reproduce it. So again, that's the summary, the first bullet point of what we just talked about. But underneath it, the second bullet point is an entirely different trial. Same thing, bacteremia patients, non-endocarditis. This was in hemodialysis patients, which we know there's a high bacteremia rate. 123 patients, pretty good. And vanco use was actually an independent risk factor for failure in this trial. And if we look at, it's kind of difficult to show, but if you look at the clinical outcomes at 12 weeks, you can see that treatment failure was much greater in the vancomycin arm. And the numbers are a little bit better here. 70-plus patients in the vanco arm, about 46 patients in the ANSEF arm. But there's a lot of things that have been nitpicked out of this study. And in fact, we got a guideline recommendation in the old and the new MRSA guidelines that, because of these questionable efficacy against just MSSA, and then also the fact that we just really want to be good antimicrobial stewards and know when to say, no to these agents. If you have MSSA, you should not use vancomycin, okay? So let's look at, so we think vancomycin may potentially be inferior to other beta-lactams for actually methicillin-susceptible staph. So now let's turn our attention to MRSA. We know that MRSA bacteremia has a huge mortality risk. It's almost twice that of MSSA bacteremia, but until recently we didn't have a lot of choices. There wasn't a lot we could use for actual bacteremia. There are quite a few more choices now. Vancomycin's cheap. It's extremely cheap. It's relatively safe. It's easy to give. But my question, my challenge for you guys will be not to say that we're here to slam vancomycin because it's an excellent drug. My objective today is to get you all thinking. Go back to your hospitals, go back to your practices, take this with you on rotations and say, maybe we don't want to use vancomycin empirically in this patient, and knowing when to ask that question. So if I can have you leave today with that kind of thought in your head is just to think about it, then I think we've succeeded. So looking at MRSA, this is a similar type of chart. This was some isolates. Again, I don't like the low numbers, but it's about 60, 70 patients. But you can see that they looked at vancomycin-treated patients. This is a study that's widely used and cited in the literature. And when you look down, you can see that vancomycin failures were much, much more than successes when used for MRSA bacteremia. And an interesting thing is not just the fact that we see yet again reproduced in another study that's often quoted, is if you look at the bottom, it seemed to be based on the minimum inhibitory concentration. So you were more likely to fail. If your MIC, we know less than 2 is susceptible, but if you were 0.5, you had a pretty even failure rate to success rate. If it went to 1, look at the difference. Much, much more failures. And if it approached 2, your failure rate was definitely not acceptable for anybody treating. So, and this last one, this group 2 AGR, this is an accessory gene regulator. When we start getting into pharmacogenomics, you're going to hear more about this. It was 80 to 85% of the patients that actually had treatment failures. When they isolated the MRSA strains, they had this group 2 AGR, an actual gene, and they're not sure. It's very controversial as to whether this is an independent predictor for treatment failure, but it will be definitely something that we'll be looking at in the future, is potentially testing patients for this. And if they do have it, maybe using something else. So again, aside from that, the MIC thing is really what I wanted to hit on. So it seems that as the MICs go up, so do the failure rates. But let me ask you again, what's the break point for vancomycin? 2. Would you know if an MIC was 1.8, like in our gentleman in case 1? You don't know when you're going to have a treatment failure or not. But the odds are stacked against you if you have a totally susceptible MIC, yet you just look at the odds. So that's kind of one thing that I want to drive home today. The other thing was creatinine clearance, very interesting in this study. We talked about vancomycin being an independent predictor of failure. So was creatinine clearance. For every 10 ml decrease in the creatinine clearance, and I found this very interesting, the odds of successful response to vancomycin in this particular study decreased by 20%. So how many people do we know, show of hands, that we treat with vancomycin for a serious infection that actually have normal renal function? Very few. So I would say it's certainly not the norm. Again, we talked about the AGR group 2 polymorphism. If that was present, the odds of treatment failure with vancomycin were almost 7 times greater. Okay? So our concepts, we hear about vancomycin resistance, and a true vancomycin resistance documented is rare. But we also hear about this concept called the MIC creep. So is this really what's happening? So I do want to do a couple of definitions just so you understand. Vancomycin resistance is just like any other type of resistance. True resistance is the result of microbes changing in ways that reduce or eliminate the effectiveness of drugs, chemicals, or other agents. The MIC creep is a little bit different, but it's the same outcome, basically. It refers to an increase in the number of actual isolates with MICs that are still susceptible, but they're higher than in previous data. So they're climbing. They're not where we were 10 years ago, or 15 years ago, or even 5 years ago. So not only do we see failures at elevated MICs that are still susceptible, we've got more isolates total. So does that make sense to everybody? Sort of. I see some like glazed over maybes. Okay. Vancomycin utilization. Again, this is showing, I don't think anybody, we really don't even need to put the slide in there to know that vancomycin use, at least now, is really high. But this goes up to 1995, and I really just wanted to show, when you look at the injectable, the yellow line, you can see it's pretty, linearly increasing. Does anybody know why it kind of curtailed off here in the early to mid-90s? This is when VRE became a big, big concern. Late 80s, early 90s, and there was a very, very large campaign to say, know when to say no to vancomycin. Do not use it unless you are absolutely sure that you need it. Okay? And it's kind of shifted since then. So if we looked at the line and went all the way out to 2010, we would probably see it going straight back up again. Okay? Vancomycin resistance, true resistance, I don't want to spend a whole lot of time on. If you see one of these, it would be a call to the CDC, basically. But this is acquisition of certain genes. The MICs are typically greater than 32. There's only 6 case reports as of right now. Hopefully it stays that way. And then VISA, which is vancomycin intermediate Staph aureus, and GISA, which is glycopeptide intermediate Staph aureus. We know vancomycin, the class is called glycopeptide. So it doesn't matter if you see VISA or GISA in the literature, it means the same thing. Okay? And these basically are sitting, right at between 8 and 16 micrograms per ml. So again, with the breakpoints at 4 and then now moving down to 2, a true vancomycin intermediate Staph aureus should show up. There's 10 case reports. There's actually more since then. And these actually, again, are a little bit different. The intermediate Staph aureus, they look different. So if we look at these, this is an actual regular MRSA as we would normally expect to see it. And you can see that the cells have very, very, finite edges, smooth borders. But if you look over here, they're spongy or fluffy looking. And you can kind of see how it looks a lot different. What this does is it can require up to 2.5 times more vancomycin to actually kill these bugs because the sponges, this material on the outside, actually soaks up the vancomycin so it can't get to the cell wall. So this is one of the theories postulated as to why vancomycin might be failing, is the presence of these little pockets of organisms with elevated MICs. So VISA, true vancomycin intermediate Staph aureus, is intermediately resistant. It has 100% of the population growing at 4 or greater, true vancomycin intermediate. Now the concept of HVISA, which stands for hetero-resistant vancomycin intermediate Staph aureus, is a little bit different. It kind of has a little bit of the good and a little bit of the bad. So what you'll see is that it demonstrates not the same type of resistance pattern to where you have 100% totally committed at this MIC. You have subpopulations of cells they have varying levels of resistance. Some may be at 1. Some may be at 1.8. Some may be right at 2. And then you might have a couple of pockets of these HVISAs that are classified as intermediate that will grow at 8 micrograms per ml if you actually isolate them out. But when you clump it all together, you end up with an MIC at or near 2. So would still be susceptible. So this is the big worry, is we can't detect it and we can't find it, but all we're seeing is treatment failures. Again, just to kind of look at it graphically, here's our vancomycin susceptible Staph aureus, and this would be our vancomycin resistant Staph aureus. And the intermediate Staph aureus, this looks at log kills. So as we go up in vancomycin concentration, you can see how easily it kills vancomycin susceptible Staph aureus. The intermediate, again, is vancomycin is not going to be appropriate for, certainly not the resistant. But H-Visa is kind of in the middle. So you really just don't know. Again, this is just summarizing what we've talked about. So let's look at the clinical data. We've talked about, and a lot of what we talked about is controversial. So what are they seeing out in the clinical setting? One study of over 6,000 isolates demonstrated an MIC shift upwards over several years. They looked at less than 1.0 versus greater than 1.0. And the proportion of increase was about 20% greater than 1.0 to over 70% in just 4 years' time. Another one, 16.2% of over 240,000 Staph aureus isolates had an MIC of 2.0, which was an increase from previous data. Again, looking at between 01 and 05, this study showed fewer strains with MICs of less than a half and increased strains of greater than 1.0 and those approaching 2. 8% in this trial were 2.0. One center identified an increase in the prevalence from 1.6 to 36% among 256 isolates. The MIC increased from a mean of 0.25 to near 2 between 1985 and 2004 in this trial. Another one, mean MIC of MRSA increased from 0.9 to 1.4 at a large teaching hospital, and that was only in 4 years. This was one just kind of showing, if you look at vancomycin, looking at the geometric mean, you can see each time they survey it, each year, it just keeps climbing. Whereas if you look at linezolid, daptomycin, they're relatively stable. So again, when you look to see if this data is actually reproducible, I think all of us can agree there's always flaws and limitations in study design, but there is reproducibility in this data out there. So again, this is just showing graphical format. And it would be fine if we were seeing kind of all of these shift up. It might just be, due to surveillance. If all of the strains with MICs, no matter what the MICs were increasing in frequency, that might mean something different. But the interesting thing is when you look, the blue line or the turquoise line here is those at an MIC of 1.0 or greater. So this is definitely increasing exponentially. The dark blue line, which was really not good to do blue on blue, so I apologize, those greater than 1.0 are increasing. But the ones with the low MICs, less than 0.5, less than 0.75, are actually decreasing. So we're not seeing a net increase. We're not even seeing one staying the same and the others decreasing. We're seeing just a total crisscross where the ones that we don't want to see are increasing dramatically, and those less susceptible isolates are definitely decreasing in frequency. So again, going back to that little study that we talked about where we had success and failure rates, and we talked about the MICs going up and failure rates going up. Let's look at this to see if it's reproducible, just like the rest. Here are the 3 that have looked at it, and we do see that the data is reproducible. No matter where you look, the higher the MICs are, the more likely you are to have a treatment failure with vancomycin for MRSA, okay? Again, you can see it here. Isolates with vancomycin MICs greater than or equal to 2. You can see it's increasing here. This is greater than 1. And then if they look at MRSA split out MSSA, they still see an increase. So I guess my goal in all of this was to show you, I really wanted to show you how much is out there. And it kind of is all saying the same thing, but it's very fragmented at this point. But again, I want you to be aware of what's out there, and I want you to at least be thinking when you're writing your protocols or treating your patients, try to keep this in mind. Quickly, just to talk about the breakpoints, they did move them. They used to be 4, they changed to 2. In about 2006 is when this change was made. And really it was due in large part to the vancomycin intermediate Staph aureus, which you can see the majority of it was sitting right at about 4 and 8. So by doing this, they would capture the majority of their visa isolates would automatically be thrown out. You would not be using vancomycin for these, and it would be very successful and I think safer for patients. The concern is the H visas predominant incidence is right here. just underneath 2. So by switching the breakpoints, if we look and we say, what does the change in breakpoints mean? When they did this, they looked at 157 strains. Two of them, 2%, had an MIC of 1. A little over 80% had an MIC right at 2. And 17.8 were an MIC of 4. Okay? This is for the H visa strains. Okay? So 100% of those would be susceptible if they just left the breakpoint at 4. So they had to move it. The question was, where should they have moved it to? So if we reduce the breakpoint to 2, 17.8%, or virtually all of those true vancomycin intermediate Staph aureus isolates would be, they'd be shown, they would be segregated out, and you would not be using vancomycin for those. I think that's a great success. But what you need to keep in mind is that, we would increase correct classification, but a lot of these H visa strains producing MRSA subtypes have MIC values at or near 2.0. So you're not going to catch those H visa strains. And we know that the higher the MIC of these strains, the bigger the treatment failure. Okay? So the take-home points. A progressive reduction in susceptibility to vancomycin is occurring in areas of high use. I guess the thought is that it's truly selective pressure by glycopeptides. MRSA is evolving, and I think a lot of it, and we'll talk about it later, it's not necessarily due to vancomycin being a bad drug. MRSA is evolving. It's the bug and it's the severity of the infections that are really making vancomycin not 100% of an optimal treatment for the majority of patients with severe infections. And again, remember, the majority of the rural hospitals that are here, our labs only report breakpoints. You don't get an MIC for your MRSAs. So my challenge, another one of my challenges for you, is to go back to your hospital, go to your antimicrobial stewardship committee, go to your P&T committee, get your infectious disease physicians together, and ask your microlab to start giving you actual MICs for MRSA isolates, both in large part because you want to try to keep a database to see where you are, what are your local susceptibility patterns, but then you also hopefully will get comfortable enough to start guiding therapies based on the results that you're getting back. Clinicians are not aware, again, of the actual MIC data if their labs are reporting only breakpoints. Drives up the cost of care. And again, remember, resistance assumes that the breakpoints are valid and accurately distinguish clinical success versus failure. And that's obviously not the case right now, right? Suboptimal dosing. We know if we don't dose vancomycin right, we're not going to get a good outcome. So we have to be aggressive at dosing, and we need to really try to do the best we can with getting the correct therapeutic levels of this drug. Remember, 80% of the organisms with the MIC right at 2 had that H visa phenotype. And if we do early empirical and aggressive dosing, we need to load the patients. That is recommended, definitely 20 to 25 milligrams per kilogram as a load. That's strongly encouraged. So again, challenges of detecting resistance in the lab. I don't want to spend too much time on this. We talked about that the lab has a lot of limitations. It has a lot of problems. Just aside from e-testing or getting your actual MICs for MRSA, what are the other things that we see? Well, could we try disc diffusion? What this shows at the top is they took isolates. This one had an MIC of 0.5. This one had an MIC of right at 2. This one had an MIC of 8. The zone diameter for each one of these, 17. Couldn't tell. Likewise, they plugged them into Microscan, Vitek, and they actually plugged in vancomycin resistant isolates, not H visa, not visa. These were overtly resistant isolates. And the results in the Microscan and Vitex largely were susceptible. So these sources concluded that the disc diffusion procedure is out. It won't differentiate strains. Also, when we look at automated susceptibility testing methods, those are also not acceptable to detect vancomycin resistance in the lab. So there's a lot of challenges. So when we look at pharmacodynamics, what can vancomycin pharmacodynamics tell us? We know that we measure antibiotics in different ways. Some are concentration dependent, some are time dependent. We know that Vanco largely is dosed like a time dependent antimicrobial. And it kills best if you look at the 24-hour AUC to MIC. So when we're trying to have a target for vancomycin to hit, I know we all target our troughs. But what that's equating to when you look at pharmacodynamics is a 24-hour area under the curve to MIC. How long is it above the MIC? The greater that number is, the better the kill we're going to get, the better the clinical outcome we're going to get. Okay? This is from the Vancomycin Therapeutic Guidelines. And basically just saying that AUC to MIC is what we target. And this is really where this magic number of 400 comes out. So if you've had pharmacodynamics, pharmacokinetics, and you've looked at vancomycin, 400 is the magic number that you try to get to. So my question to you that we're going to try to attempt to answer here over the next couple minutes is, what's the trough we shoot for vancomycin? Anybody? 15 to 20. Does that get you to an AUC to MIC of 400? Okay? So this is where they got it from. AUC to MIC is the best predictor. You can see the log kill is much better here than in these other methods. So that's just where that came from. So a little bit about vancomycin itself. Very large molecule. It has a variable degree of protein binding, which can be problematic. The lung concentrations of vancomycin are not that great, about 14%. Okay? So automatically we know that vancomycin potentially could have some issues in pneumonias, particularly those more severe pneumonias. Soft tissue, if there's a lot of inflammation, vancomycin can be less effective. Especially those inoculum sizes, meaning if you look at vancomycin and you look at daptomycin, you look at linezolid, and you look at people who have more bacteria or a higher inoculum size, vancomycin will actually do less potent killing than will the others. So if it's a more severe infection, depending on where it is, depending on how severe it is, vancomycin does not perform as well as some of the others. Since the AUC over MIC is the best predictor and low-dose exposure produces H-visa, theoretically, we just give more, right? So we give them more, we should get a better outcome. Clinically, that's not the case. There was a study that looked at troughs 5 to 10, 10 to 15, 15 to 20, looked at clinical outcomes, no difference. So, but in general, we're targeting an AUC to MIC of 400, so that means we have to be aggressive. So although we can't, beyond a shadow of a doubt say that there isn't an improved efficacy if we dose it higher, we do that. Okay, it's in the patient's best interest to hit that trough, hit it aggressively, get there early, and get the most bang for your buck, so to speak. Okay? So this AUC to MIC of 400, this is where it came from. And you can see that if we look at the day of eradication and the percent culture positive, if we don't dose vancomycin aggressively, we don't hit our target. Okay? And if we don't hit our target, it does actually correlate to clinical outcomes. So I do still strongly believe that you need to aggressively dose the vancomycin. And you can see how different it is when you actually hit your target. That's pretty impressive. So the target level, just to kind of put it in numbers for you, if we looked at achieving an AUC to MIC of 400, that would equate to a trough of roughly 20. So what do we do when we get a trough of 20.5 and a patient's on vancomycin? 100% of the time, decrease the dose, right? We're backing off because that's what the guidelines say, right? That's what we need to be doing, okay? 42 milligrams per kilogram per day is what's required for a 90% probability of reaching that AUC to MIC. Now, if we want to go even higher and say, with 95 to 100% certainty, I'm going to hit that 400. I'm going to hit that target. The studies tell us that we should really have between 56 and 70 milligrams per kilogram per day. So I'm going to pick an average patient, let's say 85 kilograms. Let's dose them at 60 milligrams per kilogram per day. How much vancomycin is that in a day? Over 5 grams? Anybody give over 5 grams of vancomycin in a day to somebody who weighs 85 kilos? It doesn't happen. There's no nomograms to address that. It doesn't exist. So really, and some data, this is, again, controversial, the protein-bound vancomycin doesn't do a thing. So your true unbound vancomycin is what you really should use. So this study actually said you really need to be over 500 for sustained efficacy, and that would be doses higher than 8 grams of vancomycin a day, which is, it's not possible. You just wouldn't do that to a patient. So what is the correct dosing regimen? So again, this is way too small to spend too much time on, but I did want to point out 2 things. These are from the Therapeutic Guidelines. It tells you what trough to hit, the 15 to 20, and how long to monitor and all that stuff. This is the basics, and all the pharmacists in the room I know have seen this. For a pathogen with an MIC of 1, the minimum trough concentration would have to be at least 15 to generate the AUC to MIC of 400. Okay? Remember the number. It's right at 1. Now down here, in patients with normal renal function, the AUC to MIC of greater than 400 is not achievable with conventional dosing methods if the MIC is greater than 2. Okay? So we're not going to get it if it's right at 2. We should get it if it's less than 1. But does anybody see anything in here about what you do when it's between 1 and 2? It's not addressed. So we just assume that it's going to work. Okay? So the take-home message here for this section is CLSI defines the organism as susceptible if the isolates are inhibited by the usually achievable concentration when the recommended dose is used for the site of infection. And we know that if it's sitting right at 2, we're not going to hit our target. The problem is you don't know in the lab because you don't know where your MICs are. Currently available nomograms, as we said, were not designed to achieve these targeted endpoints. We know that larger than recommended troughs have been shown to cause development of H. visa. We definitely know that. Or lower, I'm sorry, than recommended troughs. And higher vancomycin trough levels have not been shown to improve patient outcomes. But we still want to make sure that we, hedge our bets, do the most we can, dose our patients aggressively. But if we're not dosing aggressively, we will see an issue. So there really appears to be a clinical disconnect between what we've traditionally called vancosusceptibility and clinical success with the treatment for serious infections. So what are our options? Okay, we're done with vancomycin, finally. Are there any questions? I guess I can stop for a second. Did that make sense to everybody? Kind of walking through that? It's a lot of information, but again, my goal is not to, we don't want to slam vancomycin by any means. It's a wonderful drug, but I just want to get you thinking that it, you might not want to use it as often as we do. So what can we use besides vancomycin? This is a quick summary of trials. Telavancin, which is another drug that we'll talk about in skin, 91% versus 86%. And NSS means non-statistically significant, so a trend. SS means statistically significant, okay? Telavancin, looking at just total bacterial eradication, trend was better. Dapto, for bacteremia and endocarditis, they were allowed to use gent with vancomycin. The trend was a little bit better. Dalbavancin, again, 90 versus 82% for skin. Tigacil and ceftaroline are newer drugs, both non-inferior. Linezolid for bacteriologic eradication, 88.6 versus 67%. Post hoc, again, they pulled, you got to be cautionary when they pull stuff out of studies that the primary endpoint was never intended to prove this. But in the Zyvox study, they pulled stuff out and they said, well, what about the severe pneumonia patients? Because remember, we said only 14% of vanco actually gets into the lung. And then you have protein binding issues as well and inoculum issues. And Zyvox doesn't seem to be affected by those. So could it potentially be better? So they pulled those patients out of the study, and it was shown that there was a greatly improved survival, statistically significant among the Zyvox-treated patients. But again, you have to be very, very cautious when applying these. So the bottom line is, we're not saying that there's anything that's absolutely overtly superior to vancomycin right now, but the bottom line is we have some pretty darn good options. So here's our drugs. Is anybody still using Sinercid? Okay, pretty much for salvage therapy, I would assume. Okay, Daptomycin, for the students, I had to put the mechanism of action in here, so I'm not gonna pain you reading through those, but make sure you know them for rotations. Indications, skin, bacteremia, right-sided endocarditis, native valve, osteomyelitis, septic arthritis. Important considerations with daptomycin. We never use it for pneumonias, obviously. It binds into the surfactant in the lung, and it just renders it ineffective. It will not work for pneumonias. But it's excellent for these other indications. Usual dose is 4 to 6 milligrams per kilogram once a day. High-dose daptomycin is actually recommended, and it's in the new MRSA guidelines for very severe infections. And there were some recent case reports actually released about really prolonged life-threatening CPK elevations with a higher dose. We haven't seen it at our institution, but I'd be interested if there's any practicing physicians or infectious disease pharmacists in the room to see if you've actually seen this with that higher dose. What we have seen is a better clearance rate for bacteremias by using this dose. Of course, daptomycin has the new 2-minute IV push, which is kind of sharp from a nursing standpoint. And of course, the CPK monitoring is important with this drug. Tigacil, community-acquired pneumonia, intra-abdominal infections, and skin. There's the standard dose, pretty broad spectrum of coverage. Of course, it doesn't cover Pseudomonas. Nausea and the infusion time are there for you. Telavancin is a little bit newer. A lot of people don't have experience with this drug. We've seen very, very good healing rates with telavancin in our wound care center. It's almost like vancomycin, but it's a little bit more potent. It hits 2 areas. Vancomycin only hits 1. So it does kill at a little bit lower MICs than vancomycin does. The issue with this, there's a couple. One is that there's no monitoring, and everybody kind of throws their hats up and says, yes, no monitoring. But the issue is it's like vancomycin. So we are seeing some renal issues with this. You can see some serum creatinine rises. So be careful and make sure that you're monitoring renal function closely if you're using this. The other thing is there's some teratogenicity with this drug as well. So at our facility, you actually can't get it unless the patient's a negative pregnancy test if they're within childbearing age. And it actually alters the tests for anticoagulants. It doesn't hurt the patient. It's not raising INRs in the patient. It's actually doing it in the tube and causing a falsely elevated INR, PT, PTT. So that's something that you need to be aware of as well if you're going to use this in a patient on warfarin, that your levels are going to be off. But we actually draw the troughs of telavancin, our INRs, we draw in the troughs of telavancin about 17 hours after the dose is given, and then you know that the drug's pretty much gone, and you have a minimal effect on your INRs. That's kind of how we get around it. But it's a good drug. We'll see where it slides into therapy. The newest one is Teflaro, ceftaroline. And this is a very interesting drug because we have never had a cephalosporin that actually covers MRSA. There are some definite disparities in the literature. Teflaro is actually indicated for community-acquired bacterial pneumonia and skin, but it's not indicated for MRSA pneumonia, even though it covers MRSA. And the reason being is because they had to study it against what our current U.S. standard of care is, which is Rocephin and Zithromax. So it wouldn't be fair. Rocephin and Zithromax don't cover MRSA, so therefore the FDA made them basically write it out. So it is active against MRSA. We started using it in our wound care clinic. It's a very nice drug. The nicest thing about cephalosporins is their safety profile. They're pretty easy on the kidneys. There's not a lot of side effects. So this drug will probably be increasing in use, but the cost will be, I think, a little bit prohibitive. It's also twice a day. The other thing, future treatment options to look at, ceftobiprole, the FDA is currently holding it. It's another cephalosporin. One of the issues with Teflaro is it was like Tigasil. It doesn't cover MRSA, or Pseudomonas, rather. So we can't use Teflaro. Of course, everybody would try to use it for hospital-acquired pneumonia, potentially off-label, which we don't want. So it does not cover Pseudomonas. So it's probably going to stay in the community. But for skin, it's kind of nice. Other things they're looking at, dalbavancin, which is like vancomycin, but it actually, you give 1 injection and it lasts a week. And then you give another injection at that 1 week point. So for outpatient treatment, that could potentially be excellent. Iridavancin is another one, sort of like telavancin. And there's a couple of manufacturers that are working on this. It's NX104. We know that, going back to Teflaro, it's a great drug, but the gram-negative spectrum wasn't what we wanted it to be. Again, remember I said it didn't cover Pseudomonas. It also doesn't cover some extended spectrum beta-lactamase or beta-lactamase producing gram-negatives like Enterobacteriaceae family. So basically what this NX104 is, it's a beta-lactamase inhibitor, sort of like clavulanic acid or tazobactam. So they're going to add this they're looking at adding it to both ceftazidime and ceftaroline to beef up that gram-negative spectrum and basically make a new drug entity out of it. So they're going to be doing some unique things. But anyway. So just real quick, I wanted to touch on the new MRSA guidelines. These are some changes and some things that I picked out. It's a large document, so here are some things that you'll see. There are very few level 1 recommendations because of lack of well-designed trials, but there's a lot of A2 recommendations in there. Vanc and Zyvox for MRSA pneumonia has got an A2. Again, remember, it's controversial if Zyvox is superior. The Vanco penetration and failure rates were addressed, which I was happy to see. And the addition of rifampin to the regimen for severe infections is sort of new. We did it for endocarditis, but we're starting to see that a little bit more. And then the Vanco dosing is there, talking about higher doses for severely ill patients. The trough targets still did not change. They're still going to be 15 to 20 for vancomycin. For MSSA, again, we talked about it. They reiterated in these guidelines, beta-lactam is still the best choice, not vancomycin. And this was really nice to see. They had these research gaps, and in the guidelines, they looked at areas that they said this further research is needed in these areas. And it was really nice to see that vancomycin as the first choice for empiric therapy is actually listed as a research gap. So I was really, really glad to see that. Interesting recommendations on decolonization. Too much to get into today, but read it. It's just kind of interesting where they came up with that. Bacteremia, infective endocarditis. Vancomycin was A2. Daptomycin was an A1, which was very interesting to see. So there's subtle hints in here. For community-acquired MRSA, they listed a very nice table with risk factors. We're currently drilling these into our current students, making sure that they know the risk factors of, do you just do incision and drainage, or when do you actually send them home with an antibiotic? Because one of the biggest things we're seeing now is Bactrim overuse, and that's becoming a big issue. And knowing when incision and drainage is enough, or knowing when you really need to give antimicrobial therapy, definitely pull that chart and make sure that your students are aware of it. And even your physicians and your peer groups. For community-acquired MRSA, again, for non-purulent, they still want you to target the beta hemolytic strep. And for those of you who had me a couple weeks ago in the infectious disease lecture, remember we talked about doxycycline and Bactrim aren't very good against those groups of strep that would cause cellulitis if it was not community-acquired MRSA. So they're saying coverage for both MRSA and beta hemolytic strep, you're going to use Bactrim, doxycycline, plus either amoxicillin or Keflex. You can always use linezolid alone, but we're all well aware of the cost prohibitive issues with linezolid at this point. If it's purulent, we want you targeting MSA right from the outset. What's generally done is if it's non-purulent and we're going to give you something, we're going to give you something that targets both the strep and the presumed MRSA. If it's very purulent, not very good looking, we're obviously going to go right for MRSA. Okay? Clindamycin still should probably be second line. It was given a level A2 recommendation, but again, remember the limitations that you have with doing the D test. Not sure if that resistance is there. Plus, it's still a little bit more expensive than some of the other ones. So Clinda is still kind of one of those that should be considered, but not really as first line. But in general, with the new MRSA guidelines, they're still sticking with vancomycin first. Escalate from there. Okay? And again, my question to you guys will be, is that really, for 100% of the infections, the right thing to do? Patient's clinical response should determine the continued use, independent of the MIC. If the patient responds, continue Vanco with close follow-up, and switch to something else if it doesn't work, basically, is what they're saying. Okay? In the ICU, do we know what's the mortality rate if we don't get it right the first time with antibiotics? Higher, lower, the same? Higher, like maybe a little bit higher or a lot higher? Yeah, okay. So again, I'm trying to give you guys these take-home messages to just get the wheels turning and just start thinking about some of this, okay? And then there were some other things, like if you failed Vanco, you'd go to high-dose daptomycin. But they're basically saying Vanco first, if it doesn't work, switch. Okay? So in conclusion, you guys are like, finally. Susceptibility does not always guarantee success. We know that, especially with this. But resistance almost always predicts failure. The activity of vancomycin against Staph aureus, particularly MRSA, is questionable. It seems to be decreasing based on what we're seeing. But at this point, let's just call it questionable. Okay? If we look at tissue penetration, protein binding, organ sites, depending on if it's lung, skin, there are some other issues there. Really, for me, the MIC should drive drug selection, not vancomycin dose selection. And hopefully you guys, if you all understand that, then I think I've succeeded today. So to determine the future utility of vancomycin, we really need to get good methodologies for identifying these hetero visa strains. Whether it's, I think we can all agree that some sort of MIC testing should really be implemented. But we also need a better way to detect which people are going to fail and which people are not, even above and beyond just looking at what the MIC is. I think it's a good first step. Remember, 55 to 60% of the MRSA isolates out there today, and all of the 6 CDC-confirmed resistance have that AGR2 genetic marker. So back in the 1970s, remember we talked about Vanco when there were all resistance started to be seen. They're starting to ask, well, maybe we should really limit the use. Late 70s, we had VRE start to be documented. There was a paper released, and it was in Reviews of Infectious Diseases, which interestingly now is CID. And it was called Reassessments of Vancomycin, a potentially useful antibiotic. And what they called for was a cautious and measured approach to the use of vancomycin. And my question to you today is, should we go back to that? Should we be a little bit more cautious and a little bit more judicious about how we're using vancomycin and in which patients we use it? With numerous treatments, again, let's not forget there's not a whole lot coming out for gram negatives. So some of these new drugs with beta-lactamase inhibitors or whatever they're going to do, we're hoping and pleading that more things get into the pipeline for these multi-drug resistant gram-negative ones. That's definitely an issue. And again, we need more well-designed comparative trials. And it's really important to note, again, we've said a few times, Vanco has really not performed poorly. If you look at the comparative trials, it does not look that bad. But clinically, we're seeing these failures. So I hope that over the years, hopefully sooner, things are going to tease themselves out. So consider this as a conclusion. For severely ill patients, necrotizing pneumonia, empyema, severe bacteremia, infective endocarditis, severe skin infections, truly severe skin infections, what if we started with daptomycin, not pneumonias, and Zyvox for maybe the pneumonias? What if we started with something else empirically? And then as soon as cultures could come back, and as soon as you got the MIC for that MRSA strain, if it's presumable MRSA, you could de-escalate to vancomycin. Is that potentially an alternative? Yes, but is it potentially a better approach for those really, truly severely ill patients who we know are already at odds, and you know you're going to have to push your vancomycin dose, really push it, in light of everything else in septic patients, with or without an amine glycoside? We know toxicity increases 3 to 4-fold in those cases. So look at the big picture, especially for the pharmacists, pharmacy directors. Cheaper drugs do not mean hospital savings in all patients, okay? And molecular tests are on their way. And I'm really excited when you read through these, it's kind of neat to look at what's being tested. So they're definitely in development at this point. I threw this cartoon in there, and it's totally unrelated to MRSA. But the guy says, I like to practice before I start acupuncture treatment. So I guess my challenge to you guys is, aren't we doing the same thing if we just give vancomycin empirically to every single person 100% of the time? Aren't we just taking darts and throwing them at the dartboard and hoping, yeah, this should work? So again, the patients you treat, the cases you treat really should dictate what drugs you're using, okay? And again, does anybody know what car that is on the left? Aston Martin, the Vanquish. Okay, remember, vancomycin came from the term vanquish, right? Vanquish means to overcome, to defeat, to gain mastery over. And again, my challenge to you guys is today, when you go back to your hospitals, when you get out on practice rotations, ask yourselves, get involved in these protocol committees, and say, we're putting vancomycin on every single protocol for, as a choice, 100%. If it's MRSA, vancomycin. It's a knee-jerk response. Are we truly defeating, overcoming, gaining mastery over? Are we really maximizing positive outcomes by using vancomycin? Or are we sort of minimizing cost and we really don't know what our outcomes are going to be until 2 to 3 days after that patient gets started on the drug? And then you can make a decision. Either bail on vancomycin and go to something else and risk the mortality issues, length of stay, other things. So again, here's the site for the new MRSA guidelines. I apologize to my students who we've already made read them. Please read them. I'd be interested to see what your thoughts are on all of this, as well as some of the other things that are controversial in the guidelines. So with that, thanks for listening to me ramble for an hour, but thank you. What questions do you guys have? Anything? I either did a really good job or a really bad job if there's no questions. So yes. So are you saying? If you would withhold vancomycin? Or you mean switch to an alternative agent? Oh, okay. So yeah, I mean, in general, the argument for selective pressure, and the question is if we would stop using vancomycin, I think, as I understand you, if we would stop using vancomycin and switch to other things, would that save some susceptibility to vancomycin? The answer is we don't know. I don't know, personally. I mean, in general, you guys have heard the balloon analogy, that if you slow down using one drug or you start using vancomycin like crazy, and you squeeze on one side of the balloon, and what happens to another side of the balloon? It gets bigger. So, using judicious use of all of our options for MRSA, I think would be what I would challenge you guys to go back and talk about. to say, instead of saying, I'm not saying we ditch vancomycin because it's a great drug, and we go to 100% daptomycin. That's not what we're saying at all. What we're saying is you need to look at your patient and you need to say, this is a necrotizing pneumonia. This is a severe bacteremia. We're ruling out infective endocarditis. They've been in our wound care for 4 months with MRSA. They've tried this, that, and the other thing. Do we really want to give them Vanco again? So really looking at your patient cases and saying, I'm not just going to go down this protocol and legislate this medicine and say, vancomycin. Using daptomycin in appropriate people, using Zyvox in appropriate people, using telavancin, Teflaro, using some of these other agents to lessen the pressure on vancomycin, but almost spread it evenly, over the other agents. I think just that is really, truly the heart of antimicrobial stewardship, is the right drug for the right patient at the right time. So very good question. Thank you. Other questions, concerns, comments? Anything anybody wants to share experience-wise from their practice? You guys are like, just get me out of here. I want to go eat lunch. Yes? We look at clearance rates, and if they have routinely positive blood cultures, and I can't remember what our parameters are, but if they're culture positive beyond a certain amount of days, they're not allowed to be on vancomycin anymore. So we switch them. And if it's the bacteremias, we use daptomycin usually. We've used telavancin, although I shouldn't say that, it's off-label at this point. The bacteremia data looks very nice for telavancin. We've used it in a few patients, and clinical outcomes have been very good. But daptomycin is usually what we go to. Zyvox we will do, but the concern with the hemodialysis patients is the platelets. Zyvox always seems to just do that to the platelets. But daptomycin we have done. But you have to ask yourself, if you look at a dialysis patient who isn't doing well, what's the attributable cost to that patient, quality of life, hospital costs, time and personnel costs, and look at your cost difference between Vanco and daptomycin. And I think the answer is clear that the daptomycin is clearly appropriate in those cases. So, does that help? It's a difficult sell because of the cost. So, but for us, there's certain things that we're willing to spend more on. And there's other things that it's just an overt, you certainly don't need the more expensive agent in this number of areas, but this is certainly one that, I personally have been always very passionate about, saying that if the patient's severely ill, let's not even use vancomycin empirically. A lot of our ICU pneumonias, if there's no contraindications, we'll start with Zyvox. If it's a very severe pneumonia. No, they can. We can do daptomycin over in dialysis. We can do it in our outpatient infusion center. And I guess our dialysis and outpatient infusion center are very close to each other, so we sort of have that advantage. But they can get it either over in dialysis or in outpatient infusion. It's their choice. So, and if you have home antibiotic therapy, again, that's something that we don't do. We're starting to do a lot more of in our, or OPAD, or depending on what you call it. We're starting to do more of that in our area. But that's nice as well. So, other questions? Okay. Thank you guys for your attention. Appreciate it.